you would like to ask, you can certainly do so without that being part of the official recording. So thank you all for joining today and welcome, Dr. Poindexter. We're very excited to have you.
Can I do an introduction, Laura, before we start?
Yes, that would
Um,
be perfect. Thank you so much.
yeah,
I didn't want to put you on the spot.
no. I'm excited to. So we're really excited to have Dr. Brenda Poindexter present to the Georgia Prenatal Quality Collaborative today. She is the chief of the Division of Neonatology at Emory University in Children's Healthcare Atlanta, as well as the Marcus Professor of Pediatrics and the system lead for neonatology for Children's Healthcare Atlanta. She's an expert in neonatal nutrition, has over several decades led and made fundamental contributions to how much protein to give babies, the impact of human milk and growth, and has led a number of clinical trials focused on preterm infant nutrition and outcomes. She's served on the American Academy of Pediatrics Committee on Fetus and Newborn, which is the major guideline making committee for newborn infants, as well as is the current president of the Society for Pediatric Research. And for those that don't know, this is an organization almost 100 years old now that has about 5,000 members that are dedicated to research in child health. And so we're really excited to hear this talk, very relevant to the work we're doing on optimizing newborn nutrition.
Thanks so much, Ravi. And I've been really looking forward to talking with this group. Absolutely thrilled to be working with you all here in Georgia. Been here for a little over 4 years and have really enjoyed meeting so many of you. So it was really tough, I think, to think about talking about how to optimize nutrition in a 1 hour talk. And so we'll see what we can get through and would certainly be happy to take questions at the end. So I don't have any relevant disclosures. And over the next hour, what I thought we would do is to review some of the strategies to prevent postnatal growth faltering, to talk about the benefits of human milk and some special considerations for the use of donor milk, and then spend a fair amount of time, I think, on a really timely topic, and that is to summarize some of the current evidence related to fortification of human milk, including evidence, or in some cases lack thereof, for bovine versus human milk-based fortifiers. And I hope that some of these topics, sort of dovetail with the amazing work that you all are already doing as a statewide collaborative. One of the, kind of fundamental things is how we define suboptimal growth or growth faltering. And the most common definition really is a baby having a weight less than the 10th percentile at 36 weeks postmenstrual age. But this is increasingly, I think, an overly simplistic way to look at this. And we know that there is physiologic weight loss that occurs mostly from contraction of extracellular fluid spaces. And over the first few weeks after birth, that can be as much as almost a full Z-score decrease in weight. With many studies recording a much greater than a 0.8 Z-score decline in the first weeks after birth. And this is really an opportunity, I think, to minimize some of that early postnatal weight loss, because once we get behind, it can be really hard to recoup those deficits over the course of the NICU stay. A really important point, I think, though, too, is not just thinking about growth faltering at one time point, like 36 weeks or at time of hospital discharge. And we really need to be thinking about a change in that growth trajectory over time. And, we talked a little bit about the decline in weight, but most longitudinal studies also show sobering declines in length and head circumference Z-scores as well. So I mentioned that prevention is really the best strategy. And how do we do that? This is a very, I think, multi-component prevention strategy, including early parenteral and early enteral nutrition, early fortification of human milk, thinking about that really vulnerable transition period from when you're weaning parenteral nutrition and when you're ramping up enteral. And then just the role of standardized feeding protocols to not only reduce NEC, but also to improve growth outcomes. And I would love to hear more about, some of the work that you all are doing in some of these areas. So I really could give a whole talk on early parenteral nutrition, but I thought I would try just to summarize it in one slide. And I think that most places have gotten really good at starting amino acids immediately after birth. I think that, depending on how your pharmacy is compounding the stock solution, I would recommend starting a minimum of 1.5 grams per kilo per day, but really getting very quickly up to the amino acids. There really is some emerging studies to show harm if you go above 3.5 grams per kilo. And there's really no data whatsoever to support the need to slowly advance amino acids. I would say, and we'll show a little bit of this hypothetical nutrient delivery, but I would not start to taper the amino acids in your TPN until you're on an enteral intake of at least 75 per kilo. And I'll explain a little bit more where that's coming from in subsequent slides. But it's also important, as important as early amino acids, we really also need early lipids to be able to meet both the fat and energy requirements. And so on this front, I would say initiating 2 grams per kilo, again, sometime in that first 24 hours after birth, and getting up to a max of 4 grams per kilo over the next few days. There has been a lot of recent work on early enteral feedings, definitely, Cochrane reviews, meta-analyses, multiple types of studies have found improvement in the number of days to regain birth weight and the days to reach full enteral feedings with early enteral nutrition. If you are starting to progress feeds early, so, starting possibly at like a trophic volume and then ramping up, that has also been shown to increase the number of full enteral feeding days in the first month and to reduce the number of days on parenteral nutrition. In more mature babies, the studies in the UK, this was the SIFT trial, found that faster rates of advancement up to 30 per kilo per day does not adversely affect survival without moderate or severe neurodevelopmental impairment. One of the questions, that I have about this study, though, is just the paucity of babies born at 22 and 23 weeks, and whether we can extrapolate some of these feeding studies in bigger, more mature babies to the very vulnerable, very immature populations that we are all increasingly taking care of. I think this is sort of old news, but I would say, gastric residuals just say no. And so I think that in the past, measuring gastric residuals before every enteral feeding was a common practice, despite there really not being any evidence to support the utility in diagnosing feeding intolerance or NAC. And again, there's no evidence to support discontinuing enteral feedings based solely on gastric residuals. And there have actually been some randomized trials looking at this. They're small, but finding that if you don't measure gastric residuals, not surprisingly, babies reach full feedings sooner. And people have not found an increase in the risk of NEC by omitting the practice of measuring gastric residuals. One of the, I think, biggest things that we can do to reduce snack is to have a standardized feeding protocol. And this is from a meta-analysis that was published in 2005, where the pooled evidence showed an 87% reduction in NEC with simply having a feeding protocol. There's been a more contemporary publication on this with some more studies added, and that pooled risk is still a 78% reduction. So I think one of the best things that we can do is to have standardized feeding protocols. And it's interesting that it is less important what those individual components are of the protocol than that you simply have a protocol that everyone follows. Not that I don't think there's room, to tweak them as we have more evidence emerging. I think that we talk about, do we have a feeding protocol, but where we sometimes then drop the ball is not measuring and monitoring whether the feeding protocol is being followed or not. I think that understanding failures is really critical, because often it's the bedside provider that, if they're feeling anxious about a particular part of the feeding protocol, I think instead of dismissing it and saying that they're a late adapter or they're just, a little more difficult, I think understanding what they're worried about can often lead us to go back sort of to the guideline and say, do we need to learn from whatever it is that's causing people to be anxious? You need to do buy-in when you're rolling out a feeding protocol with sequential small tests of change or PDSA cycles. And then I think whenever possible, integrating the guideline into the clinical workflow to make it more automatic and harder for people to not follow the protocol. And then I sort of alluded to this, but once your feeding guideline is developed, I think it should never be viewed as being final and should always really be in a state of modification so that new evidence and new learnings can be incorporated. Well, I feel like I'm probably preaching to the choir here on the benefits of human milk for our population. But it is a species-specific diet. It's been shown to decrease infant mortality and lower the risk of NEC. I think with some of the recent developments that have been in the public arena with some of the lawsuits against the formula companies, I think it's really important that we as leaders in healthcare are able to articulate the difference between associations and causations. But human milk has been associated with a lower risk of NEC and with decreased in-hospital morbidity, including rates of late onset sepsis, BPD, and severe ROP. One of the, we've known for a long time that human milk confers important benefits in terms of neurodevelopment in term babies. But one of the first large studies to look at this in the preterm population was actually a secondary analysis that Betty Vore did of the Neonatal Research Network parental glutamine trial. And we had really detailed nutritional data on more than 1,400 ELBW infants. And at the time that this study was conducted, 75% of the babies received human milk during their hospital stay, and only 30% at the time of hospital discharge. I think that this is, really sad that this was the state of things, and it really speaks to quality improvement work that has happened in the past few decades to increase that. But what Betty was able to demonstrate is that for every 10 mLs per kilo of maternal milk that these ELBW infants received, there was a dose-dependent increase in both the Bailey MDI and PDI. And the difference that was seen at 18 months persisted until preschool age at 30 months. And I think this is really remarkable because of how few babies went home on human milk. And so I think it really speaks to the power of early nutrition in making a difference in outcome for our babies. Well, in addition to some of the nutritive components of milk, we know there are anti-infectious properties, there are enzymes, trophic factors, all of which help to confer some of these antibacterial and anti-inflammatory effects. The oligosaccharides exert important prebiotic effects, and the clinical correlates of many of these include lower rates of sepsis and NEC. And I think we have so much more to learn about the complex biology of human milk and how that's altered when we're using donor milk or, having multiple freezing and thawing cycles, and so much more to learn about this with regard to our preterm babies. So when, we've already said that maternal milk improves outcomes, and now a number of bodies, including the AAP, have said that when maternal milk is not available, that pasteurized donor milk really should be what we're using for babies less than 1,500 grams. I think some of the questions as we're talking about strategies for how we fortify milk, something to keep in mind is, do we need to alter our practice or our standardized guidelines when babies are receiving primarily donor milk? Compared to preterm maternal milk, we know that the nutritional profile of donor milk is more similar to mature milk of mothers who have delivered term babies. And then we know that the milk processing of donor milk, with the freeze thaw cycles and additional handling, can also dramatically impact the nutrient delivery. This is an example that I always love to talk about with our nurses at the bedside when they're asking, can we switch from bolus feeds to continuous feeds, because the baby's had a few spits or whatnot. And so if you just look here at the column with the fat, if you take milk and then you just look at the fat content after pasteurization, after thawing, after feeding by NG bolus, when some of the fat is going to adhere to the tubing, and then look at how dramatically different the fat content is if you're infusing continuously. And so, not that there aren't times where continuous feedings are appropriate, but I think that for that to be the default, you just have to be mindful of how much of the nutrient density you're losing by altering the handling or how you're infusing the milk. So one of the questions that came up is, if we know that maternal milk improves neurodevelopment in our extremely preterm babies, would they receive the same benefit to neurodevelopment if they receive donor milk? And so there have been two large randomized trials, one conducted by Debbie O'Connor in Canada, and then the second, the milk trial, which was led by Tara Khaleesi for the Neonatal Research Network. Both studies enrolled babies that were born less than 1,000 grams. The milk trial specifically targeted moms who either were not intending to provide their own milk or had a low maternal milk supply. And these trials were really, when they were started, we did not have as widespread usage of donor milk. And so babies were randomized as a supplement to the base diet of maternal milk to either receive donor milk or preterm formula. And the primary outcome was looking at the Bailey 3 cognitive scores at 24 months corrected age. Both of these large trials found no difference in neurodevelopment between the donor milk and the formula group. I think that, it was maybe contrary to the hypothesis that there was not a neurodevelopmental advantage to donor milk, but I think also reassuring that the donor milk outcomes were not worse, because we do worry about growth in babies that receive mostly donor milk, which can also impact neurodevelopment. And not surprisingly, both of these studies found a higher incidence of stage 2 NEC or greater in the infants who were exposed to preterm formula. The investigators of the Domino trial, the primary outcome was really looking at that Bailey 3 score as a continuous variable. And what they did in a post hoc analysis is to kind of look at the cutoff for babies that had a Bailey score less than 85. And they found that a higher percentage of babies in the donor milk group compared to the formula group had a score less than 85. But again, no difference in the mean score on the Bailey. So certainly something to look at. And then in the Khaleesi trial, the infants in the donor group did have slower weight gain despite aggressive, I would say, fortification strategies. So just something to keep in mind. So why is it important to fortify human milk? It's nearly impossible to meet the metabolic demands and recommended nutritional intakes without fortifier. This includes things that are needed, such as calcium and phosphorus, to optimize bone mineralization. And then also, although there have not been studies to show a definitive association between fortification and neurodevelopment, we do know that having improved growth in terms of weight gain and linear growth are related to better developmental outcomes. So I don't know that there will ever be a study to compare fortifying versus not fortifying, but rather how can we adjust fortification strategies to really optimize outcomes. This slide is one of my favorite ways to explain some of the inherent differences between preterm maternal milk and donor milk. And so what you're seeing here is just the protein content over time and weeks of lactation. And so the blue line is showing the protein content of milk from a mom who has delivered a preterm baby, starts out high and then starts to decline, and probably by about 6 to 8 weeks of lactation has transitioned to having similar protein content to term milk. And then donor milk is variable depending on sort of what stage of lactation the mom who has made the donation is at, and can also vary with whether the Himbana Bank, how many donors they're pulling together, and if they're doing target fortification for protein. But definitely lower than if the milk is coming from a mom who delivered prematurely. What's always been fascinating to me is that if you look at the label for the recipe, when you're adding fortifier to a base diet, the manufacturers have to make some assumption about the protein content of that base diet. And it sort of depends on which brand you're using. but they roughly assume a protein content of around 1.5 grams per deciliter. And so they're really looking at that as being static. And so if you're adding fortifier to maternal milk, say at 2 to 3 weeks of lactation, then you're delivering very close to what that label says. But if you think about where our babies in the NICU spend most of their time in the hospital out here, we are systematically delivering less protein than intended. And if you're not really paying attention to that and closely monitoring their linear growth, that could be a unintended sort of, you know, way that you're giving less protein than you intended to. And so again, I would ask the question, do we need different feeding protocols for babies who are receiving mostly donor milk? Well, to get around this question, when I was in Cincinnati, one of the fellows that I worked with, we were doing human milk analysis of the donor milk that our babies were receiving, and found, like so many others, that the protein content was very low. And so one of the things we did as a quality improvement project was to go ahead and add a modular liquid protein to the donor milk before it ever was used to prepare feedings in the NICU. So almost to take that donor milk and add a gram per deciliter of protein to make it come closer to the protein content of preterm maternal milk. And then people could use it as part of the standardized feeding protocol. And this slide just shows the weight and the length z-scores. It's probably hard to see, but the donor milk is here in the solid line. And then the two different dotted lines represent the maternal preterm milk and babies who received what we call donor milk plus, or just the donor milk with the added protein. And so I think through some lacto engineering, we were able to overcome the low protein that we were getting from the milk banks in the donor milk, and then finding improved growth as a result. Now, one of the ways that you can think about delivering more protein is just based on when we're fortifying. And I think that over the last decade or so, I mean, it used to be more common to wait to fortify until the baby reached full volume feedings of somewhere between 130 to 160 mils per kilo per day. There have now been studies evaluating different timings of fortification, some as low as 20 to 40 mils per kilo per day. I think that, the earliest practical time point that you would want to fortify would be when a baby's receiving a total of 25 mils a day, just to limit wastage of maternal milk. This kind of shows some hypothetical aspects of protein delivery. The dark black bars are showing protein from parenteral nutrition. The kind of lightest gray ones are showing protein from human milk feedings. And then the kind of medium gray are showing when fortifier is added. And these are just hypothetical deliveries, but with the point being that if you stop parenteral nutrition early and you wait to fortify until the second week, you've got this period in the middle where you're really not delivering as much protein as intended. Obviously, if you start fortification earlier, you're going to increase your total protein delivery. And then if you more slowly come off TPN and start your fortifier earlier, then you're going to be able to deliver more protein. It's not that one of these is the right answer, but I think paying attention to kind of balancing that desire to get the babies line out and get them off TPN, but also realizing that if you're not fortifying, that you're having a week or more of really a time where you're accruing more and more deficits, and that can have really long-term kind of consequences for those deficits. Okay, and now I'm going to shift to kind of talking about the different fortifiers that we use. And I would love to hear if this has been part of the work that you all have been doing with the Optimizing Nutrition Project. We already talked a little bit about what I would call a single component fortifier, like the modular protein that we were adding to donor milk. But a single component is usually used in conjunction with a multi-component. And so the multi-components can be bovine or human milk. They can be powder or liquid. The type of protein may be intact or hydrolyzed, but it was going to supply sort of a balance of different kinds of nutrients. Whereas the single component, like the creams or the modular proteins, are typically used in conjunction with a multi-component fortifier. There really have not been, I think, enough studies on some of the different fortifiers. Some of the newer bovine products now will have extensively or partially hydrolyzed protein. And it's not clear if those are more favorable than the ones that have intact protein. I think we've tried to get away from using powdered fortifiers in the unit because of some of the contamination issues that have been rarely reported. But I wonder if there may be a role for powders in the future, mostly thinking about when you're using a liquid product, you are by definition displacing more of mom's own milk than you would be with the addition of a powder. When people talk about sort of an exclusive human milk diet, what they're really talking about is a base diet of maternal or donor milk, and then the use of a human milk-derived human milk fortifier. These are expensive liquid products that are offered in a large range of caloric preparations. And I think you could argue this is an advantage or a disadvantage depending on mom's milk supply. But the thing to keep in mind is that, especially at the higher caloric density, you are displacing sometimes up to 50% of maternal milk. And again, if mom has a waning milk supply, that may actually be desirable. I think some of the most recent reports say that about a quarter to a third of our facilities in the U.S., large delivery facilities, are using the human milk based HMFs. And so what I want to spend some time talking about is really what is the evidence for differences in outcomes between bovine versus human milk-derived fortifiers. And I'll walk you through some of what I think are the most sentinel studies in this area. And then sort of at the end, maybe propose where I think there are some research gaps and maybe what the ideal fortifier study would look like. And really want you to, as we go through these studies, sort of thinking about what are really the critical questions regarding a base milk diet. And when you're looking at these studies, it's really important that you're looking at what base diet was actually studied and what did the babies actually receive. And so, you may have an exclusive human milk diet where the baby is getting either maternal or donor milk and the human milk-based fortifier. And that's really, I think, the definition of an exclusive human milk diet. Or you may have a combination of mother's milk and donor milk with either bovine fortifier or bovine fortifier and formula. And so you really have to pay attention to, when you're looking at these studies, what percentage of the infants received exclusive mother's milk, what percentage received primarily donor's milk, again, thinking about the differences in the nutrient content between the two, and then how many received a mix of both. And, does the population that was studied, does that apply to your population? So one of the studies I think that really gets quoted probably more than a lot as being a reason to use the human milk-based fortifiers was the trial that was done by Sullivan, published in JPEDS in 2010. And she enrolled 207 babies, 500 to 1,250 grams, whose mothers had an intention to provide maternal milk. And so they, the intervention group, they received the base diet of maternal milk. And then when maternal milk wasn't sufficient, they received donor milk and they received the human milk-based human milk fortifier. They had a subset of the patients in the intervention group that the fortifier was started at 40 per kilo per day, and then another part that was started at 100 per kilo per day. And for the final analysis, they combined them because they didn't see differences in the group, sort of lending support for earlier fortification. And then in the control group, the babies received maternal milk. But then if maternal milk wasn't sufficient, they received preterm formula and then the bovine human milk fortifier. And so, really a true head-to-head comparison of the fortifiers isn't possible in this trial because of this, what I would say, contamination with preterm formula. The primary outcome was the days of parenteral nutrition and growth, and they followed babies until the earliest of 91 days, hospital discharge, or reaching 50% of oral feedings. And so I'm gonna have you look here. This is the outcome of NEC. And so again, these are the babies who received the bovine, received formula and bovine fortifier. And the incidence of NEC and NEC with surgery is shown. So 16% had NEC and 10% had surgical NEC. And then you look at the babies who received the exclusive human milk diet, again, pooling the early and the later fortification groups. And you see a 6% incidence of NEC and less than 2% of surgical NEC. And so Alan Lucas did a secondary analysis of this trial and found that of the original 207 babies, there were 114 who only received maternal milk-based diet and then the fortifier. So if you think back to this slide, it basically, his secondary analysis took out both the donor milk and the preterm formula. And so kind of in a post hoc secondary way, was able to do a head-to-head comparison. And so you can see here for the exclusive human milk and for the bovine diet, the rates of NEC, surgical NEC or death, and then overall mortality. Again, finding in favor of the exclusive human milk diet. But I would argue that this, this is not what the study was really powered to do, and with only 114 babies, with only 32 in this exclusive human milk diet group, is really not adequately powered to make a meaningful conclusion. So the next study I want to talk about is a trial that was done by Debbie O'Connor. She was the same one that did the Domino trial that we talked about earlier. And she enrolled 127 extremely preterm babies. The intervention group received the exclusive human milk diet, and the control group, this time, she took away that contamination of preterm formula. So the base diet was truly all human milk, either maternal or donor, and the only bovine exposure was the bovine fortifier. The primary outcome was enteral feeding tolerance, and she followed babies for a similar period of time as the Sullivan study. And so in this group, among the infants that were less than 1,250 grams at birth and exclusively fed human milk, the use of the human milk derived fortifier did not improve feeding tolerance or reduce morbidity or mortality compared with the bovine. And I'm showing here the rates of NAC in the groups, which were similar. Although kind of an interesting, they did find a reduction in severe ROP in the babies who received the human milk fortifier. And then the last study that I want to talk to you about is the most recent one. And this was conducted in Sweden. This was the Jensen trial. And they enrolled infants 22 to 27 and 6 weeks who were exclusively fed human milk. And then they did a true head-to-head comparison of the Prolacta human milk-based fortifier to bovine. Their primary outcome, I think, is very relevant and was a composite of NEC, sepsis, and mortality. And in this study, they, again, the part of the reason that I think they looked at the composite outcome of NEC, sepsis, or death is that they would have needed well over 1,600 babies if they wanted to power the study only for NEC. And this study was actually stopped early, but found really no difference between the groups. I think some of the relevant questions and concerns to ask with this study is that they had an extraordinarily high rate of maternal milk use, which is great. Only about 5% of the babies in this study were exposed to donor milk. And so I think you have to ask yourself if that is generalizable to the population that you care for. The bovine fortifiers that they used, again, this study was done in Europe. They did use some that were powdered. They used a lot of different products. So some had the intact protein, some had partially hydrolyzed. They were also able to use probiotics. And again, the study was terminated early because it showed that they would have needed many more babies to show a difference in the primary outcome. And so, I think that when people say, oh, this trial showed that there was no difference, I think we have to be really careful because, actually, it really never completed the full intended enrollment. So, sort of based on all of these studies, in the most recent edition of the Nutritional Care of Preterm Infants text, I think that the overall consensus, which a lot of the recommendations in this book really are just that, our expert consensus statements, was that at this time, there is no evidence to justify recommending a preferential use of human milk-based fortifiers, which are far more expensive. But I think that we all would agree that more studies really are needed. And I would love to hear this group's thought on if we would want those studies to be powered for NEC or for neurodevelopment or maybe other outcomes. I think that's a really important question. The other question I think is, does it matter what the baby's gestational age is to start the fortifiers? So a lot of the studies that have looked at fortification have included much bigger babies, up to 1,500 grams. The Jensen trial was really the one that limited it to the smaller babies. And most of our recommendations for feeding and for fortification are weight-based. And, I think that thinking about babies that might have experienced intrauterine growth restriction or might be small for gestational age, I think that we have to also be mindful of maybe we need gestational age recommendations. I've really focused a lot of this on preterm babies, but I think that we do have a number of special populations in the NICU, babies that seem to have intolerance to bovine products, perhaps babies who, have already developed NEC, and we're thinking about the feeding protocols we use following NEC. Infants with single ventricle physiology or with GI anomalies, I think are areas where we can't assume that what we've always done for kind of the vast majority of preemies would be appropriate for them. So lots more work to do in this area. They're important to think about the microbiome, and certainly we know that microbial diversity is influenced by exposure to maternal milk. It doesn't seem that the use of the human milk-derived fortifiers has any advantage on the microbiome compared to the bovine fortifiers, but really not a lot of work in this area. I think some emerging data on looking at the impact of exclusive human milk diet on long-chain polyunsaturated fatty acids like DHA and arachidonic acid. Definitely need to learn, more about that. And then something that I'm sure that you all are seeing increasingly is just parent refusal of both formula and bovine fortifiers. Some of this, I think, is related to some of the recent lawsuits, and how do we handle this? I think as a subspecialty of neonatology, as individual hospitals, and have we reached the point where we need to consider obtaining consent for use of bovine products? I want to kind of wrap up by talking a little bit about when we stop fortification. Again, this is not an area that has really been subject to high quality randomized trials. I think it depends on what type of fortifier is being used and is typically guided by clinical judgment, how the baby has grown, how they're doing with PO feeding, how close are they to going home, and sort of what are mom's plans for when the baby goes home, how much direct breastfeeding are they going to be doing. The Cochrane review that I mentioned earlier, really kind of concluded that fortification does improve growth, but does not really provide clear evidence of benefits beyond 34 to 36 weeks. The European Society, ESPGHAN, recommends transitioning off of fortifier when they are about 2 kilos or about 36 weeks postmenstrual age. I'm not aware really of any US-based guidelines for when we discontinue fortification. The studies that have looked at the human milk fortifiers have typically transitioned off again around 34 weeks. With the bovine fortifiers, some have transitioned when they're ready for a discharge diet. Some parts of the country will actually send babies home with fortifier. So again, there's really not a lot of data to support practice. And so I think this could be a great area to do additional quality improvement work in. So let's kind of wrap up with, just briefly talking about future research to advance the field. And so I would say that we really need long-term studies that compare fortifiers to look at growth, neurodevelopment, and metabolic outcomes. We need innovation to reduce some of the cost of these human milk-derived fortifiers and to improve nutrient composition. I didn't really have time to talk about things like vitamins and zinc and calcium and phosphorus and how we might optimize that in fortifiers. We probably need more research to expand knowledge and just how to best use human milk analyzers so that we can do more of a precision medicine kind of approach with individualizing the way we're approaching nutrition in some of these babies. I already mentioned some of the micronutrients and vitamins, figuring out when is the optimal time to transition off of fortifier. And then I would still argue that I think we need a large randomized trial to do a head-to-head comparison of our current fortifiers and to be really thoughtful about what we would want the primary outcome of that study to be. I'm not sure that all centers still have equipoise to do such work, but I think that it is really important. So just to conclude, I think that human milk is the preferred nutrition source and should really be fortified with a multi-component fortifier to support short-term growth outcomes. I think there's insufficient evidence to support the choice of the human milk-based fortifiers over the bovine. Either can be used, although long-term advantages or disadvantages are really unclear. Likely to need additional fortification or modular agents to achieve optimal growth, especially if the babies are seeing a lot of pasteurized donor milk. And then I think that we need more studies for newer generation fortifier products, possibly with more extensively hydrolyzed protein. And probably more important than anything else is that the single most important intervention we can do in the NICU is really to support breastfeeding and to help mothers provide milk for their preterm infants for as long as possible. And I know Michelle's on this call, and I'm so excited about the work that she is doing to address some of the disparities in moms who are able to provide milk for their babies. So with that, I will thank you all for your attention, and if time permits, I'd be happy to take any questions.
Oh, thank you so much. That was amazing. Give me just a moment to stop the recording.
And I'm happy
then
to
I would
share
love
the
to take questions.
I can send those out. I'm always happy